but the efflux of CSF is very slow. Now, many times when you do spinal in your clinical practice, you often feel the perfect click. Your hands are trained, ladies and gentlemen, but you don't see CSF. You whip it out and you put it in again. The question is, we all expect the CSF to gush out like in an obstetric environment. Now, these are elderly patients. So in this particular situation, we could see the tip of the needle in the neuraxis, in the thecal sac, but there was no CSF efflux. We even aspirated, no CSF. But we injected the local anesthetic, perfect spinal. So a dry tap necessarily doesn't mean you haven't entered the thecal sac. This is my message to you. But if you are doing it blind, would you be brave enough to inject the drug? I would not advise you do that. But if you're using ultrasound, yes, many a times you will find that your needle is in the thecal sac, but there's no CSF. So dry trap is more common than you think it is.
Sir, in a difficult spine, as you explained so nicely, I just wanted to know, when you are doing the sonoanatomy, the ultrasound, does the positioning of the patient makes a difference, like in a sitting or lateral position in all these cases? I just want to know that.
Yes, I think it does make a difference. But in most situations, you have to adopt the position that you would like to use for the intervention. And as I said, I prefer the lateral position. But sometimes appreciating the complex anatomy of the spine can be difficult. Now, because I hope you are prudent and you do most of your intervention in the lumbar region, and lumbar interventions are quite easy to do in the lateral position. And if you just have that one single position, then it really doesn't matter which way the changes are different in the sitting or lateral position. So there are differences, but what they are, it has to be delineated in future dedicated research.
Thank you, sir.
Yeah, once again, Manoj, excellent talk. I wanted to know routinely, can we use ultrasound guidance in mid-thoracic paramedian approach routinely, because we know how challenging to get into mid-thoracic level?
Yeah.
And next question, ultrasound application in elderly patients with osteoarthritic changes.
Good questions. I have the answer for you. But I think in the interest of time, maybe we can discuss at length later on and I can show you some videos. But I'd just like to say in brief is that yes, I think what you have posed is a very important challenge that occurs to most experienced anesthesiologists. Thoracic epidurals in the challenging individual. We do paramedian epidurals, and I'm sure most of you do paramedian because this is much easier, there are reasons for it. But often when you do it in these cases, sometimes the needle is deviated towards the contralateral side. I often see that the needle's been introduced 6 centimeters, 7 centimeters, no loss of resistance, loss of resistance. But this is not epidural, it's on the contralateral paravertebral space or in the contralateral pleura. I'm not saying pleura, but contralateral pneumothorax have been described. So when you do paramedian scans in the thoracic region, the acoustic window is much narrower. You still have to do that oblique scan. The degree of tilt you apply on your transducer is the degree that you tilt your needle from the midline. So my advice to all of you here is learn to do paramedian sagittal oblique scans of the thoracic region. It's very simple because it's a shallow structure. You can guide the needle in plane to the lamina. Once you hit the lamina, put the transducer down and do what you normally have to do. I can say in my practice, in most of the cases, I often reach the thoracic epidural space within the first attempt, and often within less than a centimeter. Because you see, you've introduced the needle very close to the ligamentum flavum or into the ligamentum flavum. And therefore, thoracic epidurals become very simple, very objective, and very easy. There are not published data, but this is our experience, and we have a lot of it. And I can show you later on.
This is the last. Yeah. So what is your opinion about the patients with ankylosing spondylosis? Because in those patients, they are having osteophytes in the neuraxial spine. And one of the cases which actually we have done, which is a relative of a spine surgeon, he suggested don't go for regional anesthesia. Patient is not fit, means he's also having spondylosis in cervical spine. Replacement surgeon supported us. We gone ahead. we use a combined technique. We can reach the space, got the spinal, but we cannot thread the epidural. So what is your opinion on that? Can you give a tip on this?
I think that's a very interesting question, and it's very good that you have raised that. It was not part of our curriculum today, so I did not comment on it. Now, when you look at ankylosing spondylitis, we think it is a difficult situation. It's a difficult pathophysiology. But I think when you look at what lies underneath, you can get a lot of information by some of the incidental investigation that these patients often have. And I refer to a CT or an MRI. Most of these patients have a CT or an MRI. If you are in a hospital environment where we have a PACS system, where you can access this radiological data, we can do that in our hospital. We can review CT MRIs in our operating rooms, and we can render in 3D, like the radiologists look at it, and we can plan the procedure. So what I'm trying to tell you is, before you put your needle in, you must know where is that open space. And most of the time, the open space is L5-S1, ladies and gentlemen. So you look at the published literature, whether in the Saudi Journal of Anesthesia, maybe this is your publication. I don't know, there's a publication, whether you look at in other publications in anesthesia, analgesia on ankylosing spondylitis, it's through L5-S1. But the authors haven't told you why they did it through L5-S1. Because the L5-S1 is the last intervertebral space to close. It is the widest, right? So it's usually the last to close. So if you have an opportunity, this is your last opportunity. And as I say that when you do a scan and you can see the anterior complex, the anterior complex is the posterior surface of the vertebra and the anterior dura. Now, we call this the anterior complex because as an anesthesiologist, I have no business to be there. We are often interested in the posterior complex. But the anterior complex is a very telltale sign that if you see the anterior complex, there is a hole there. If the ultrasound energy has entered and come out, that means there is an opening there, and this is the same opening you can use to introduce your needle. So hopefully that will answer your question.
In one of the
yeah. Sure. I think that is another very useful improvisation.
We have done total hip replacements with caudal catheters and did it with a DAY study, and we found that catheter could go to L3-4.
Yeah. I think it's very, very good comment, and I think if you are involved with that and you have access to this, don't only think about the L5-S1, look at the caudal space. But the problem with the caudal space is we do it occasionally. We have also done it occasionally in patients with operated backs with post-operative myositis ossificans. Means you get these operated backs, but as a result of scarring and development, most of the posterior elements are ossified as part of fibrotic and osseous repair. So it's difficult to put it through the L5-S1 or L3-4-5 space. Then the caudal space. But again, one of the things is it will depend on the type of surgery you are doing. If you're doing total knee replacement, total hip replacement, yes, it's possible with you may need a larger volume of local anesthetic. Or may I say that the spread of the drug may be very variable and very different from a normal individual.
in one of the laminectomy patient at L4-5 and herniation reaching up to L4 level, what would you suggest for spinal, whether L2-3 level or L5-S1 level?
Again, I would see what the anatomical abnormalities are in that patient.
No abnormalities.
Now, if you are in a situation where you can access the CT MRIs, I would look at the CT. I would render some of these images and see which particular opening is best. You can certainly do it through L4, L5, but it depends on the type of surgery. My preference would be to go to L5-S1. But it will depend again on whether the L4, L5 is open or not. So if you have a post-operative back, like an instrumented back, and you find L4, L5 is open, I think it may be preferable to go through L4, L5 because the problem of dry tap will not be there. Because if you put it through L5-S1 and you don't get CSF, if you're not experienced and you did not attend this lecture, then you would whip it out and try probably an umpteen number of times. So don't tell anybody this secret because you travel from far and wide, and I came from far too. So,
No, I did it in single shot,
Yes.
without manipulation at L2-3 level.
right. You were probably lucky, sir.
Okay, thank you very much to both the speakers, and it was a wonderful talk during the tea break. I think so you all can share notes with them. And one thing in common with both of them was they have something with Northeast India, and Northeast India is very famous for people with they are very good at guitar. So I think so. I hope both that commonality is there.
Yes, I think I do
Thank
that
you.
too.
Small little exercise that we're all going to do before we start this session. I would like all of you to pick up your mobile phone in your left hand. Please, just for my benefit, please pick up your mobile phone. A lot of you would have a small little button that puts it on the silent mode. I would request you to kindly use that. In case people do not have that button, please go into settings and pick the silent mode. Let's please accord that respect to every speaker and to all the participants here. Thank you very much. Moving on. Our session, till lunchtime, we are going to have one big session which is broken up into smaller sessions. This session is going to be on the regional anesthesia techniques of the upper limb. And the chairpersons for this session are Dr. M.K. Aora, who is the professor of anesthesiology at AIIMS, Dr. U. Valecha, who is the HOD of anesthesia at BLK Hospital, and Dr. Anil Ohri, who is the HOD of anesthesiology at the Shimla Medical College. May I request these gentlemen to please come up on stage? So our first sub-session is ultrasound-guided and nerve stimulation techniques, how I do it. And our first speaker is Dr. J. Balavenkat Subramaniam from Coimbatore, who is going to be speaking on interscalene approach to the brachial plexus.
Respected chairpersons, senior members of the profession, and dear colleagues, at the outset, on behalf of the Aora National Executive Committee, would extend our sincere thanks to the entire organizing team of Fortis, led by Dr. Deep Aora and team for having done an excellent job in putting this conference into a great shape, and I'm sure it's going to turn out into a very meaningful one for the promotion of the safe practice of regional anesthetic technique in this part of the world. We started with very interesting sessions this morning. However, we all realized that each one of us in this country, a vast, huge country, more than 50,000 anesthesiologists, have different kinds of thoughts when they come to this meeting. All of them have seen a resurgence of regional anesthetic techniques in clinical practice and its relevance to modern anesthetic practice. So many of them wanted to move from the classical way they have been performing blocks using just the anatomy and a needle to a peripheral nerve stimulator, and those who have been using peripheral nerve stimulator wanted to go into ultrasound. And few of the institutions have got the opportunity. It's increasing. In the past 3 to 4 years, we have seen tremendous amount of ultrasound coming into clinical practice in this country. So it's basically a heterogeneous group of people who have come here to make sure that they become better in what they've been doing. So this session, as per the organizer, is aimed at all this heterogeneous group. So we would start from the basics, and one of the most important block which majority of the people wanted to have it in their control is to give an appropriate interscalene block so that they would see their upper extremity surgeries go very smoothly. So how do we do an interscalene brachial plexus block? It's one of the beautiful diagrams which shows how these nerves are. The brachial plexus is sandwiched between the scalenus anterior and the scalene medius. And when you do an interscalene block, you know that you're blocking it at the root level of the brachial plexus. And you also know that it's a very, very superficial block. And before embarking on a block, it becomes mandatory that we keep all the gadgets ready to treat possible complication, including local anesthetic systemic toxicity. So it becomes mandatory that you have an oxygen source, a suction, a monitor, and the gadgets that are required to give a successful block. And it's also important to time out and make sure which side that you're going to block and an intravenous access. Now, you could see this video. It's got an audio. Finding out the interscalene groove almost is equal to defining a successful upper extremity block. All those who are able to define the interscalene groove correctly and place the local anesthetic solution in the groove will surely get a very successful block. How to identify the interscalene groove? Let me demonstrate this on a 50-year-old patient who has come with a fracture in the forearm. Now, if I could show you the anatomy, here you see the sternal notch. You see the sternal head of sternocleidomastoid. You're seeing the clavicular head of the sternocleidomastoid. Then this is the clavicle and this is the head of the humerus. Now, what is more important is to identify the groove, and the way I do it is in relationship to the lateral head, the lateral border of the lateral head of the sternocleidomastoid. Now, to begin with, you have identified the sternal notch. If you just go up, you palpate the cricoid. And cricoid is at the level of C6. From the cricoid, you just bring your fingers back at the level of C6. And when you cross the lateral border of the lateral head or the clavicular head of the sternocleidomastoid, tell yourself that you have to go another 1 to 1.5 centimeter laterally. And then if you see that now I'm at a place which is roughly about 1 to 1.5 centimeter lateral to the lateral border of the sternocleidomastoid, and here I am palpating the apex of the scalene triangle, scalenus anticus medially, scalenus anticus medially, and the scalenus medius laterally. So I am at the apex. If I take out my finger, you can see the external jugular vein is crossing the apex of the scalene triangle. In 95% of the times, you always see the external jugular vein crossing the apex of the interscalene groove. So once again, I'm going to palpate. So now I'm palpating it more than once. I want to make 100% sure. I roll my finger so that I'm palpating the belly of the anticus and the belly of the medius. Having done that, the next thing I'm going to do is, I'm going to stretch the skin slightly. Because it's a very labile skin over the interscalene groove, many people make a mistake if they don't make the skin taut there. When they introduce the needle also being blunt, there is a possibility that the needle doesn't enter the groove correctly. So now I have identified the groove, rolled my finger, made sure that I'm feeling both the anticus and medius. I have stretched the skin here. And the nerve stimulator that I'm going to use now is the Stimuplex DIG machine, which you can see there. This is the basic version. I've kept a milliamps of 1.5 milliamps in the peripheral nerve stimulator. Here you see the positive electrode, which is connected to an ECG electrode. The negative electrode is connected to the Stimuplex needle. So now, since the circuit is complete, I am palpating the apex of the scalene groove, and I'm just going to tell the patient, "Namor chinna usi." So I'm trying to introduce the needle into the. So now, as you see the contraction of pectoralis major, deltoid, biceps. I'm slowly decreasing from 1.5 milliamps to 1 milliamps, and 0.8, 0.74, 0.6, 0.5, point. So that's the one which showed an interscalene approach. And now we have catheters which can be threaded, like the one which I'm going to show you was the Contiplex non-stimulating catheter using a peripheral nerve stimulator. The only difference being you need to make sure that when you use a Contiplex catheter, you do the primary block after you identify the correct evoked motor response, and then you put the catheter inside. So this is a patient for non-union of the humerus. So we are just about to thread the catheter into the interscalene groove. In fact, I'm palpating the pulsations of the subclavian artery lower down in the interscalene groove. As I said, it's a non-stimulating catheter. And once you see the contractions, and as you all know that it's very vital that all of us have to know the end response on the blocks that you're going to give. It's very vital to delineate and demarcate between the right kind of evoked motor response. We will do it in the workshop on Sunday. This is the primary block. Once you got the stimulation, you give the primary block, then you remove the needle and thread the catheter inside. So that's the Contiplex. I have another minute left where I would just go into the... Now, this have been a part of the practice, and many of you would like to become, if you're using the landmark technique, to come into using a peripheral nerve stimulator. For those who have got ultrasound and those who want to go into ultrasound, I think you will know the basics of ultrasound. You know that this is an in-plane, in short axis. Then this is the out-of-plane approach, which many of the anesthesiologists now practice in the initial phases. And then if you want to thread the catheter, you have to go in-plane long axis. Now, if you see the scan of the interscalene region, this is actually the supraclavicular approach. You see the subclavian artery, and posterolateral to that you see the brachial plexus. Now I'll go into the video of scanning this from medial to lateral. You see the carotid artery. Can I have the pointer, please? So, you would see the nerves appearing here. These are the C5, C6. We're getting that this is an echogenic needle which is coming in towards C5, C6. On either side, you see the scalenus anticus and the scalenus medius. And you would see the tip of the needle here. And as you inject the drug, the hypoechoic zone increases. So when you do an in-plane technique on the interscalene approach, you could come from medial to lateral. First notice the carotid and the jugular. The jugular you could compress. When you come laterally, you see both the scalenus anticus and medius, and you see the brachial plexus. Here, as you know, the connective tissue is much lesser than in the periphery. So you would see a hyperechoic rim with the hypoechoic region. So this is common with the monofascicular nerve fibers, which are the more proximal fibers. So it's very vital to see the tip of the needle and its relationship to the nerve, and then you inject the drug. So in the practice of regional anesthetic technique, interscalene becomes the most and foremost important one for all of us. And it's such a pleasure to get your interscalene block right when you're in the initial phase of regional anesthesia learning process. Thank you very much for your patient hearing, and if there are any doubts, you can ask me.
The question and answer session will follow after we are done with all the subsessions. Our next speaker is Dr. Manikandan R., also from Coimbatore. He's going to be speaking on the supraclavicular approach to the brachial plexus.
Good morning, everyone. I thank the organizers and the delegates for giving me this opportunity. I thank the chairpersons. And I'm going to talk about supraclavicular approach to the brachial plexus, which is often called the spinal of the arm because of its rapid onset due to the compact arrangement of the plexus at this level and complete form of anesthesia below the level of the shoulder, making it good for any surgery below the shoulder. And many of them do not consider it as easy, safe, and successful, similar to the spinal, because the most feared complication is pneumothorax. Now, this technique is 103 years old, started in 1911, and there have been up to 20 techniques described in the literature. Most of them are attempts to improve the technique as well as preventing the complications, mostly pneumothorax. And recently, the ultrasound technique was developed over the past 1.5 decades. It has got clear advantages of better visualization of the nerve structures and needle tip and spread of the local anesthetic. It reduces the execution time of the block. So before going to the technique, a little bit of anatomy. The concept of anesthetic line of the upper limb was introduced in 2003, where imaginary line is drawn from starting from the apex of the interscalene triangle, midpoint of clavicle, deltopectoral groove, and axillary pulsation at the armpit. So this line overlies the normal course of the brachial plexus. So if you have this in mind before going to the technique, it will be useful. So this video is about closer look of the nerve roots. You can see the dome of the pleura is very close to the subclavian artery here. And each of these roots arise at a different inclination. The lower ones are difficult to see with the ultrasound machine because of the angle. And you can see the roots forming trunks, the formation of which is difficult to recognize in the ultrasound. The block is done at the level of lower trunks and upper divisions. So these are the equipments we need. I need to emphasize upon the most two important things is the sterile cover and sterile gel, because ultrasound machine is a non-disposable medical device and you are using it on the surface of the skin where you are going to breach. So other than that, you need all the sterile equipment precautionaries. And because this block is a superficial one, we need a high resolution linear array transducer, and with appropriate footprint. The regular one is the adult, and you can see the smaller one which can be used for a pediatric patient. And positioning, some prefer to do it in semi-sitting position and some do it in supine position. We prefer supine position, and with the neck rotated to the contralateral side, and with the pillow under the shoulder, you can see the exposure of the supraclavicular forces gets better with the pillow under the shoulder in this obese lady who's 110 kgs weight. Regarding probe position, commonly described technique is placing the probe just behind the parallel to the clavicle, as you can see here. And again, is another more oblique coronal plane where you can see a 90-degree cross-section of the subclavian artery and the plexus behind it, as you can see from this image. And looking from above, this will be the usual probe placement behind the clavicle, where you can see the edge of the pleura, the first rib, and the brachial plexus. And if you go a little bit oblique, this will be useful for out-of-plane technique also. You can see the exact cross-section of the subclavian artery and the rounded structures of the brachial plexus. And most of the time, the undersurface is formed by the first rib, giving you protection. So when you place the probe, you expect to look at the subclavian artery and bunch of grapes. So a black hole and a bunch of grapes. So you can see the artery label here. These are all very clear images. You may not see it in all patients. So this is a very beautiful image. Sometimes you can see image like this where you can see, you don't see a clear bunch of grapes, but the divisions are all spread out till the anterior surface. And in some pictures you can see the pleura. And the lower two ones are the images of pediatric patients. Okay. So there is the advantage of ultrasound where you can see the anatomical relations between the brachial plexus, subclavian artery, pleura, and the first rib. So here you can see two white lines. Usually pleura is confused in the beginning stages with the first rib. So the difference is first rib is a bony structure beyond which you see only the acoustic shadow. But for pleura you can see a comet tail appearance as you can see here. Sometimes you can see arteries taking off. Most of the time you can see these arteries taking off from the subclavian artery, and there are about 19 variations of these artery structures. So you can see the most commonly seen is the dorsal scapular and suprascapular artery. So when you see these arterial structures, you need to avoid puncturing these arteries. So that's the advantage you can see here clearly. This is a scanning technique of, it's a not so great plexus. You can see the artery. So what I do is scan from the midline of the trachea just to see a bit of the extent. You can see the thyroid and sternocleidomastoid. That's the thyroid, sternocleidomastoid, and the carotid vessels. And there you can see the lateral edge of the sternomastoid, you can see the scalene vessels looking like a butterfly, the anterior scalene and middle scalene, and the hypoechoic nerve structures in between them. So when you start seeing them scan along the groove caudally, so they can see the entirety of the plexus. So now you know that the entire plexus is here and you can manipulate your needle to block. Again, when you scan upwards from the interscalene groove, you can see the nerve roots going inside the vertebral foramen. See, that's the C6 vertebral foramen. It is easy to see C7, C5, and C6, but the lower ones are very difficult unless the patient is asthenic or in a pediatric patient. So this is a longitudinal image of the nerve roots arising from, this is a pure nerve root arising from the foramen. So those who see the things from the origin itself can be able to appreciate the nerve structures well and perform the block well in a safe manner. Okay. This is the ultrasound guided technique, the sterile block tray preparation. I prefer 10 ml syringes so that I can appreciate the injection pressure. And this is a position with the neck turned to the contralateral side and pillow under the shoulder. And you can position the ultrasound machine based upon the handedness of the operator and the site to be blocked. And this patient is sedated and oxygen has been supplemented. And you need to monitor also. So the needle is entering an in-plane technique. So you can see the plexus clearly here. I kept it to the far end because so that the angle of inclination is better, so that the incination is better. So while injecting, the person needs to monitor what is the pressure. So she has injected air bubble, making it obscure. So the needle is approaching to the corner point, which is commonly described, where the C8 and T1 is located. So you see the needle clearly advancing towards the plexus, and you can avoid the intraneural injections. This is a nerve stimulated guidance technique. It's the block tray with all the equipment. Patient is asked to lift the head to give prominence to the clavicular head of the sternomastoid and feeling for the interscalene groove. So you feel for the interscalene groove and palpate it, go caudally and feel for the subclavian artery. So immediately lateral and posterior to subclavian artery, the needle enters, looking for the twitches. So this twitch is coming from behind. This often confuses and leads to failed block, maybe because of the stimulation of dorsal scapular nerve or the suprascapular nerve. So this one is ideal. So it's got a pectoralis contraction and deltoid also. But more ideally would be a distal twitch. So I am trying to manipulate the needle and to get a distal twitch. So I got finger movements here. So So I would prefer to inject it at less than 0.5 milliamperes. So at 0.5 the twitching is still there. At 0.4 it is still there. If it is less than 0.2 milliamperes, we should not inject it. It can be intraneural. Okay, at 0.2 it has disappeared, so I am safe to inject now. So the final injection is done at less than 0.5 milliamperes. And one needs to aspirate and watch the pressure while injecting and talk to the patient if you are doing it in a brain technique. And this is just to tell you that what are other contractions can be seen. So here the needle, this is a percutaneous electrode, you can see the diaphragm contracting here. So that is because of the stimulation of the phrenic nerve. And here this is the posterior contraction, which is probably due to stimulation of the nerve to rhomboids, or sometimes suprascapular nerve. So here is the pectoralis contraction. This will be an ideal point of insertion of a needle. And when you go along this puncture point, you need to elicit a distal twitch for the block to be successful. And these are the other nerves which can be seen. So phrenic will be anterior. If you get phrenic, you're anterior, you need to walk posterior. And next is the brachial plexus. And behind the brachial plexus, if you are around the scalenus medius or posterior to that, you can see all the stimulation of dorsal scapular or nerve to levator scapular, which all will give contractions from behind the clavicle. So any contraction anterior to the clavicle will be better. I finish with that. Thank you.
Thank you, Dr. Manikandan. Our next lecture is by Dr. Ashit Mehta from Sholapur. He is going to be speaking on infraclavicular approach to the brachial plexus.
The previous speakers have talked on blocks above the clavicle. I will be talking on blocks below the clavicle. That is infraclavicular approach to the brachial plexus. I will be talking on vertical infracoracoid technique. I will be covering following points in this: how the block is different from other blocks, what are the advantages of this block, how the PNS guided block is performed, how to perform ultrasound guided block, why to combine ultrasound and PNS technique in this particular block, and what the literature wants to say. The block is different from other block is that in the fact that it's a deep block, it's away from the central neuroaxis, it's away from the pleura, not in a compact space, and it's a high volume block. There are certain merits of this approach. Life-threatening complications are avoided, like pneumothorax, central neuroaxial block. We can go with bilateral blocks as there is very minimum chance of phrenic nerve palsy. A specific hand positioning, working on the PNS guided technique first. In this, the patient is lying in a supine position with the head turned completely on the opposite side. I palpate the coracoid process just below the clavicle by moving my finger laterally. The first bony prominence which I get is a coracoid process. I go 2 centimeters medial and 2 centimeters downwards. This is the point of entry of the needle. The moment I insert the needle, I get the twitches either of pectoralis major, minor, or maybe of the lateral cord first, or most of the times it is the lateral cord first. It is pectoralis major, then the pectoralis minor. Some manipulation of the needle is always required at this level, and we will get twitches of the lateral cord, that is a musculocutaneous nerve. If we move this needle a little bit, we will get the twitches of the posterior cord. This is the end point of this block. Getting posterior cord twitches is the ideal end point, and getting these twitches at 0.3 to 0.4 milliamperes. The best response for this block is, as I have told, it is the stimulation of the posterior cord, that is radial nerve, that is finger extension. The twitches which should be rejected at this level are of musculocutaneous nerve and of the axillary nerve. It's a high volume block, so it needs a very high volume. It's about 35 to 40 ml. But there are certain disadvantages of this PNS technique. It's a deep block, so vascular punctures are known, and compression in this area is very difficult. It's a high volume block, so needs higher doses, multiple stimulation technique we may have to use. So we can take the help of ultrasound at this level. In this, the patient is positioned supine with the head turned on the opposite side. We use a high frequency probe, a linear transducer, a parasagittal pen, just medial to the coracoid process, inferior to the clavicle. We usually use the implant technique. The cross-sectional view at this level shows us axillary artery, axillary vein, two muscles above it, pectoralis major, minor, and a pleura on lower side on the medial aspect. The brachial plexus is surrounded around the axillary artery according to the names: lateral cord laterally, the posterior cord on the posterior aspect, and the medial cord in between the artery and vein. So this is the pictorial diagram. This is how the ultrasound picture looks. The pectoralis major, pectoralis minor, the artery surrounded by the cords. And this is how the spread of the drug should be. Here there is one more maneuver which we can make this block more easy by abducting the arm up to 110 degrees. This is helpful as it stretches the brachial plexus. The three cords of the brachial plexus come together, and it also enhances nerve stimulation. It also reduces the distance between the skin and the brachial plexus. But as we know, there are certain variations at this level. The posterior cord is usually situated on the posterior aspect at about 6 o'clock, but it can go at the level of lateral cord. So taking the help of a PNS will guide me whether I am at a right place or whether I am stimulating a right cord or not. Secondly, there are certain artifacts of the ultrasound. The ultrasound wedge passing through the axillary artery may produce hyperechoic shadows on the posterior aspect which resembles the posterior cord. So a PNS guided technique with ultrasound will help me. There is always a tip needle angulation. It is more difficult in an obese patient, difficult to visualize the tip, so I always take a help of a PNS whenever I do this procedure. So I always do a combined procedure. So this is how a patient is positioned. It usually needs 10 centimeters needle in an obese patient. The pulsatile artery, a pulsatile artery, a pectoralis major muscle, then a pectoralis minor muscle, and the cords, that is the posterior cord situated at 9 o'clock, then the lateral cord on the lateral aspect, and the medial cord in between them or slightly above. It can be placed slightly above. When we pass a needle and reach the lateral cord, we will start getting the twitches of the lateral cord, that is musculocutaneous nerve. So here I confirm that I am near the lateral cord. Then I still proceed my near ahead to get the twitches of the posterior cord and inject my drug here. So this is the posterior cord. I have confirmed with the PNS technique. I can withdraw the needle and put it at the medial cord, which is usually placed between the artery and the vein. A combined ultrasound and PNS technique is more useful in such deep blocks, as there are anatomical variations in the location of the cords. The ultrasound will visualize and PNS will confirm the cord. It will help to minimize the time required to perform the block. Specific cord can be selected for post-operative pain relief. It avoids vascular puncture and pleural punctures, and the dosage can be reduced. But what the literature wants to say, the use of ultrasound appears to permit the accurate deposition of local anesthetic perineurally and has the potential to improve the success and decrease the complications of an infraclavicular brachial plexus block. In this study, they have conclusion that ultrasound guided infraclavicular blocks is more rapidly performed and is of a better quality when neurostimulation is not used as the endpoint of the injection. These are the studies on needle placement, where a needle placement and injection posterior to the axillary artery predicts successful block. It's a study of only 3 cases. It's a comparative study between a single injection and a double injection. Then again a study between a single injection and a triple injection under ultrasound, with the conclusion that the optimal site for local anesthetic placement during ultrasound guided infraclavicular block is single point injection posterior to the axillary artery. Then there is a study where they have evaluated the ultrasounds, it's an ultrasound evaluation, the spread of the injected associated with radial and median nerve type of motor response during a infraclavicular brachial plexus block. And they are with the conclusion, they have demonstrated that as compared with median nerve type motor response, injection performed after radial type nerve motor response promoted reproducible and remarkable ultrasound spread characteristics associated with complete sensory block of the 3 cords after 30 minutes. It's a study between a supraclavicular and a infraclavicular block with ultrasound, and they have demonstrated that the time required is same and the quality of sensory block is equal. It's a comparison between the 2 techniques of ultrasound, that is a medial approach technique and a lateral approach technique. Here the medial approach technique, they mean to say that the hand is abducted to 110 degrees, where they have seen that this medial approach is faster, easier to perform, has lower incidence of tourniquet pain, vascular punctures and pneumothorax. Is ultrasound guidance superior to conventional nerve stimulation for coracoid infraclavicular baxial blocks? In this study, they have said that the ultrasound guidance and nerve stimulation provide similar onset time, success rate and duration of motor blockade for coracoid brachial plexus block. The ultrasound guidance reduces the time required, but here they have not mentioned about the complications. These are some of the references, and thank you.
Just one request, please. I think speakers are taking longer than their scheduled time, and we're... Okay, that you can take. So I would request all the speakers to please stay within their time limit. Our next speaker is Dr. M.V. Kumar from Bangalore. He's going to be speaking on the axillary approach to the brachial plexus.
Organizers for giving me this opportunity to speak here. And namaste to all. Okay, the topic is how I do a brachial plexus axillary block. And here I would like to say is how I do and how we do should be the same, which in turn translates to the standard of care which we provide to our patients for safe regional anesthesia. Okay. Now, basically, axillary block is meant for below the elbow, forearm, ideal for forearm, hand, and everything. While planning the block, not only the dermatomal patterns we should look into, also the myotomal and the osteotomal patterns. Has to be looked into. Now, in axillary block, what is the important structure is the identification of the axillary artery, and as you all know that we target the roots here which is surrounding the axillary artery. So I think Dr. Bala Venkat and others have already told about the basic tenets of a regional anesthetic block, that is monitoring the patient's IV line, etc., etc. And here what I would like to stress is on the aseptic precautions which we have to take while doing a block. Now here in axillary block, the arm is abducted to 90 degrees, taking care not to hyper abduct the arm. And then you can see the probe. We use a high frequency probe which should be placed perpendicular to the axis of the arm, just below the insertion of the pectoralis major. Here one of our colleagues is doing the block here. What we forget to do is to wash like a surgeon, at least 3 minutes of a surgical scrub and a gloving in a sterile way. And for a single shot block, this is sufficient. The draping and patient preparation is also like a surgeon's. But when you place a catheter, I think our aseptic precautions should be a little more. I think we should wear a gown, cap, mask, everything. Make sure that the asepsis is maintained throughout the procedure. Okay. Now, in ultrasound, we first identify the axillary artery, the pulsatile, and the next structures which should we identify is the axillary vein. Here, a number of times you can see the axillary veins may be more than 2 or 3, and usually they are positioned between 12 and 3 and between 5 and 9 o'clock positions, surrounding which next we should identify the triceps, the biceps, and the brachialis. The next structures of interest for us will be the 4 principal nerves. The median nerve, ulnar nerve, and the radial nerve are usually surrounding the artery, whereas the musculocutaneous nerve is between the brachialis and the biceps, or if you scan higher up, it will be in the substance of the coracobrachialis. Now, this is one thing which we routinely do, preparation of the probe. And one of our colleagues, Dr. Sajna, was very innovative. This is a sleeve cover for the camera, very inexpensive. It is about 30 rupees only. And this is how we do it routinely for all the blocks. You can see it, the probe being passed through the sterile cover. You can see the tip is exposed. And then we put jelly for the coupling agent without touching the sterile cover. And then taking care to cover the tip so that there are no air pockets in the footprint of the probe. So once this is done, the next step is the local infiltration. Now here one of the important things which we should know is most of these blocks are very superficial, and when they are superficial we use the sharp bevel needles, and we must take care that the needle doesn't go too deep in, because sometimes we can cause neural injury if you go too deep in. So you can see the local fill when we are giving, so near the nerves there. And the first nerve which we target is the radial nerve, which is at about the 6 o'clock position. You can see the in-plane approach being done. The needle is approaching the axillary artery, and a little bit of manipulation. I am giving a small aliquot of local anesthetic so that the space gets filled up, and ensure each time when you inject that you see the local anesthetic fill, and you can see feel a click there, and then the local anesthetic fill is seen, and you can see the radial nerve there. Now many times it's not that easy. It's like navigating through a traffic. Now here one of the difficult places where we had a radial nerve block is when you can see here the number of veins, the axillary veins. You can see the needle approaching there. And here while seeing this, you can see shadows. These are all called reverberation artifacts. This is because of the reflection of the ultrasound waves on the needle. And you can also see the needle being bent. That is called a bayonet artifact, which is because of the velocity of the ultrasound waves in different tissues. Now I'm gently positioning the needle. I'm hydrodissecting, and I'm manipulating the needle between the artery and the axillary vein to access the radial nerve there. And I'm using a short bevel needle, and you can see the radial nerve being pushed up also. Now There we deposit the local anesthetic. And when we do this and we target the nerves so well, you don't have to give high volume blocks. You can give only with 3 ml to 4 ml and that will suffice. Now the next nerve which we target is the ulnar nerve, which is superficial and lateral here. Now it is at around the 2 o'clock position, you can see the ulnar nerve here. And same thing, we use the hydrodissection technique to identify the nerve and then inject the local anesthetic. So once I hydrodissect, I can see clearly. I go a little further in and now you can see the ulnar nerve very well. It's floating in the thing. And when you do this type of block, even with a 2 ml to 3 ml, I think the block results will be very good. You can see nicely the ulnar nerve being floating there. The next nerve will be the median nerve. Now here the median nerve is at this junction around the 12 o'clock position. You can see the needle tip and once again a local fill on the median nerve. So this block was totally performed with about 12 ml of local anesthetic totally, and the anesthesia lasted for about 2 hours, analgesia was almost for about 14 hours. The last nerve which we block is the musculocutaneous nerve, is between the biceps and the brachialis. But if you see here, I purposely put this thing, the needle has overshot and the musculocutaneous nerve is somewhere here. So we'll have to be very, very careful of tracking of the needle tip while doing block. Just because we have an ultrasound doesn't mean to say that the neural injuries is less. We always should keep track of the needle tip. And the gain also has not been adjusted properly here, but here in another video you can see the musculocutaneous nerve seen very well here. And because I'm using a short bevel needle, I can place the thing very near the nerve so that we can reduce on the volume. Okay, now this one of our patients with lipoma of the axilla. Now this is quite a tricky situation where based on anatomical landmarks it's very difficult to, even a PNS technique may be very difficult because we cannot feel the axillary artery. Even ultrasound is not the answer because of the fat there, it will impair the visualization of our nerves. So probably here we could use the technique of both ultrasound as well as a PNS to identify the nerves. Or we can change our technique to another block. And I take this opportunity to welcome you all to Bangalore for Aora 2015 for this 5th national conference. We have a registration counter here, and if you register during this thing you get quite a big discount. I'm not going to talk about PNS because I do not practice PNS at all, but I think during the workshops you will be able to do things, and I would advise you all to practice both ultrasound as well as PNS because I'm only good at ultrasound, not at PNS. And if my machine breaks down, I'm like a blind man. So if you have the technique of using both, I think our patients will benefit from that. Thank you very much.
Our next speaker is Dr. Amit Dikshit from Pune. May I please request speakers to load their presentations right here because this seems to be wasting a lot of time. And we are running over 20 minutes late, which is not nice. So please, after the speaker, if we could all just load our presentations.
Good morning, everybody. I thank the chairperson and the delegates to give me this wonderful opportunity to speak on something different. We are on fourth year of Aora, so this with fourth year, we all have learned to some extent different blocks, and now we are on second generation. So my presentation is, just a minute. I'm sorry, yeah. So distal blocks, it's not coming. If you could help me.